Okay, so tonight's session is when Parkinson's interferes with my ability to speak, and it's part of our recently diagnosed online guide series with the Inova Parkinson's and Movement Disorder Center. So today's program is going to cover four main topics. We're going to hit on the impact of difficulties with communication in day-to-day life. What do those communication issues look like? Factors that may affect communication in Parkinson's, and not just Parkinson's, but other components. And then how is it best managed? Getting to the first topic here, we see a range of areas that can be influenced by changes in communication. And there's obviously a lot of interpersonal interaction and relationships. It can affect you if you're still working in a work environment. It can have a lot of implications in professional settings. Daily life and independence, sometimes when you're getting services or you need help on the phone, those kind of areas where people report having issues with communication. And then along those lines, facilitating healthcare delivery. You know, if you're going somewhere for treatment or if you're going in for something, election, surgery or something like that. And that sometimes means that you have some challenges where you have to educate those people in those settings to make sure that they give you, what you need as a person living with Parkinson's. And then globally, we look at this and we see a lot of different emotional and psychological impacts of having changes in communication. And this came from our survey. We had another great, really wonderful response. I think we had 38 when we're done, and we got through them. And so I'm going to read through some of the things people were saying about the impact of the communication. So one person is telling me that they tend to avoid former social activities. Or I avoid speech interaction with strangers, and that makes sense. People who don't understand what's going on can be very frustrating. I avoid loud restaurants. That's a common complaint. People asking me to repeat myself more often, and I think that's an early clue sometimes. And then here must be someone talking about their spouse saying he gets frustrated and says, never mind. And I think that means that you've gotten to a point where the communication breakdown has gotten pretty serious, and we want to address it. So when we asked people specifically whether they noticed any significant changes in their communication abilities over time, 4 out of 5 people said yes, more than 80%. And that tracks with what I think we would see clinically or what we see in our own groups of people that we work with. And people are talking about the voice not only being softer, but it's raspy. And we'll get into why that might be. Speaking too fast or too slow, that's an interesting conundrum because Parkinson's often is associated with slower movements, smaller movements. But with speech particularly, there can be a kind of parallelic or fascinating speech that can be very fast. And then people being told that they speak too softly. And I think that's a real theme. A matter of fact, again, coming from the survey, so many people were saying soft voice, soft speech low voice, and so on and so on. Changes in the volume of speech are so common that they're almost a hallmark of the disease to me. If you come in and we're working with you and your voice hasn't changed and you're not talking about that, it's not that it's not Parkinson's, but it might not be straight idiopathic Parkinson's. There might be some other issues along that. Cognition is another big area where people report some concerns and some difficulties. And it mostly revolving around word finding issues or maybe keeping track of the conversation while they're speaking, they're losing words. Speaking slower is another really common component, and that happens. This slurred speech I put here mainly because sometimes when you have a cognitive demand while you're trying to communicate, you can distort the way you're speaking and it can alter the way that the words come out. And so that can kind of come across in different areas, but I put it in cognition. Now, fatigue itself is a very common issue in Parkinson's, but we're speaking particularly here when you're talking and you have to talk for a long time or at a higher volume and your voice wears out pretty quickly. And along that goes with strain where you maybe get some hoarseness. And so this is all, again, coming from the survey, and it really helps guide us when we're building the slides we're going to talk about today because these are real key issues that I think we need to be addressing. So, moving forward, what do communication issues look like in Parkinson's? What's occurring here? And when you talk about communication, I put it into 2 big baskets. You have on the one side, you have all the things that are involved in making speech. And that starts with your breath support and your diaphragmatic control so you can make a column of air. And then that goes through your voice box, your larynx, your vocal folds. And that makes a vibration. And then you shape that with your lips and your teeth and your tongue and your soft palate. And that becomes the communication, the speech communication. So on one side is all the production, motor speech, we would call it. And on the other side is the language. And language, sure, you have word choice and you have the way that you might be speaking in different contexts, but it also includes a lot of nonverbal communication. So eye contact and nodding so that people know that you're following them. And the way I'm talking, sometimes I might emphasize certain words by adding a little bit of pitch change or a pause. And that's the process and intonation. And then along all that comes some of the stuff that we were talking about with cognition, where you have some attention and memory. You're trying to track the conversation while you're having it, but maybe you're pulling from something from a long time ago, and you have to have that memory in addition to the right in the moment, your visual spatial sketchpad kind of memory. And word finding's in there, and we're going to get into that directly, but it's all this big conglomeration of different components, movement related plus cognitive, and then you have to do it in real time, usually while you're doing something else, like you're walking or doing something, with a dishwasher or on the phone or whatever. So why are there speech changes in Parkinson's? What's happening here? And I make the analog that whatever you can see, whatever's happening externally, so maybe a loss of facial expression, maybe it's smaller steps, maybe your handwriting is smaller, right? All those things that are happening externally are things that are also happening internally. So the rigidity, if you have soreness in a joint and maybe it doesn't move as well until you take your medications, well, that can happen in the muscles that are involved in pitch change. And if you're moving slowly and maybe not with as much distance or much energy, well, that can happen with your lips and your teeth and your tongue. And so all of a sudden you're not getting your teeth, your tongue back to the roof of your mouth or the back of your front teeth to make a certain sound, or maybe it's happening slower. You can have tremor in the structures of the mouth, and that can also be an influence. It's not as common, but it's not unheard of by any stretch. And then, you can have other components that might involve that. Like I've had people talk about having that feeling in their diaphragm, which is what helps with breath support, or maybe the rigidities in the diaphragm and they can't get enough control, or maybe their postures change. And so again, all these external factors that you can see are happening in all these places that you can't see. And that's why we have these speech issues, the communication issues. One thing I want to talk about very specifically is the vocal folds. And the vocal folds are two pieces of skin that come together, and you put a column of air through them, and once they get to a certain amount of pressure, they vibrate. And in people with Parkinson's, quite frequently, instead of being fully patent, fully closed, I can speak here, they are open a little bit. They have a little gap, and it's called a bow. And so what will happen, instead of getting a nice seal and making a good vibration, you might get partial vibration. And what will happen then is that the air will leak through there. You won't have as much power, and that air might also cause some white noise, some static noise, some shh sound, and lead to more imprecise sounding stuff. When you have noise like that in your signal, it's hard to hear. So typically speaking, when you exercise, you can close those vocal folds, but at rest, it's very common. I won't say it's a hallmark, but if I was doing an evaluation of the vocal folds, you see it very frequently.
Yeah. Now, similar to all the symptoms in Parkinson, just like communication and speech will also be influenced by different factors. And if we are able to identify, factors that make the speech worse, then maybe we can pinpoint better what we should be addressing. So it's always a way for us to manage any symptom in Parkinson is to think about what makes it worse and what makes it better. And on that, we decided to try to go through some examples of factors. I would say the number one that we should always think of in any symptom in Parkinson is always, what is the relationship of this symptom to the time of my medication? So we know that the medication is considered highly efficacious, right? So for rigidity, for slowness of movement, So when we don't have our medication, we will have more difficulty in performing our activities. And so this is when we considering situations where there's more fluctuations. This is what the phenomena people consider on off. And so that means in the off period is when the medication is not it's not doing what it should be doing. And so just consider if we are having communication problems like early in the morning. It's very often that people tell me, I can hardly hear my husband in the morning. And so it's a very specific moment of the day where the voice is actually low. And it's probably regarding the moment that the medication is still going to be taken and going to start doing effect. So just keeping that in mind. But obviously the medication exists so that it can help you. So that means we are recognizing here that sometimes if we forget to take the medication, we might have more problems, or in moments where the medication might not be working so well and we have to think about why, then our voice can also be compromised. We take the medication so it can help us in specific areas.
It's very interesting because the medication may also provide some benefits for communication. We'll see the benefits that she's mentioning here. So typically it's going to be the movement related components, the speed of the movements, the articulation of the lips and the teeth and the tongue going to the right place. And then also it might also help with volume, although volume has a lot of components. So it's not consistently going to improve volume, but it can for some people. I do see some people who absolutely show better response. And it's just because a lot of what's happening with the volume is perceptual. So this is I'm talking the volume that I always talk. This person needs a hearing aid, or, I feel like I'm shouting when I'm doing the treatment with someone. And in reality, perceptually, their volume is quieter, and it's basically a mismatch of their sensory system. And then on top of that, maybe the muscles are a little bit atrophied, and so they're not providing the work. And that might be going back to the bowed vocal folds. One thing that's interesting when you look at studies that talk about the influence of medication, particularly dopamine replacing dopaminergic medication for Parkinson's on communication, is that while those components of speed and articulatory precision, those improve, intelligibility doesn't seem to improve for whatever reason. And that probably has to do with a matter of the other components of communication. So you can improve the things related to movement, but there are other components, and some of that could be cognitive, that could be breath support, that could be perceptual. It could be a lot of components to it. So DBS also in the same boat, but DBS has other components, and we'll get into that a little bit later on. I'll make sure I'm not leaving out.
So another factor that we can think of is posture. And this is a challenging one for us to actually think about because it's supposed to be automatic. And so it's quite difficult for people during the day always correcting their posture. If you're living with someone, it's very common that people that are around you will be cueing you to have a better posture. But the truth is it's very difficult to incorporate this. But I think you can all agree that if I have my head lower and I'm looking down to the floor, my voice will be softer. And if I want to talk with someone, upstairs and have to look up, you can see that you can project better the volume and your voice. So I think it's always thinking about how, if I'm in a specific situation where I really want to be heard, can I do something about my posture that will help influence that? So either if I'm sitting down and I'm not being able to communicate so well, and if I stand up, maybe I will be able to place myself in a better position to be able to project, my voice. Yeah. Just keeping that in mind, that sometimes it's where we are sitting and how we are sitting or standing, right? And it's something that sometimes we don't think about so much.
I think it's really important when you think about posture too, to consider where you're aiming a signal like that, and also what information you're taking in. So if you are a little bit forward leaning, maybe you're not taking in some of the information that's coming in from the room. Or often when we're communicating with somebody, we use our eyes a lot more than you think. Obviously, you listen with your ears, but we get quite a bit of information from the visual system. And I think that's another component. So I think it's a great thing to focus on, and we do it a lot in our classes. Not entirely apropos here because the research wasn't done on Parkinson's, but there's also interesting research that shows the influence of posture, particularly a forward-leaning posture, on alertness and on cognition, not cognition like memory loss, but more like attention-related cognition. And so again, I think it's a really underused focus.
Yeah, and I would add in that obviously if we're focusing on our posture, it also relates to balance, right? So if you are in the standing position and you are not feeling so steady, that means you are allocating some thought to, I don't feel really balanced, I'm not really safe. And so being able to keep up a conversation with someone when you don't actually feel very comfortable, I think can be another factor that is highly challenging. So maybe in those situations is making sure that you are maybe touching something that will help you make it more automatic, your standing position where you are in space. So it facilitates that a bit. And if possible, have these conversations when you're sitting down for many reasons. One, to facilitate communication. That's what we're talking about today. But also standing up and having a conversation with someone is also hard on your posture and on your back and on your legs. And so at the end of the conversation, you are not going to feel really good.
I like the idea of grabbing onto something, just to give you a little external support. Yeah, excellent. Along the side with posture, it comes to breath support. And again, posture has a huge influence on that. As far as your forward-leaning posture might make you less efficient in the use of muscles, but also maybe coming back to the medications a bit, there's rigidity that can occur. Rigidity is just muscle stiffness. It's the term that we use. And that could be an influence of the medication. So you can have rigidity that affects your rib cage or even the diaphragm or the muscles around there. And again, if you can't produce enough air and you can't do it consistently and in the time that you want to, timing issues are common, then it's going to be really hard to communicate the way you want to. It's maybe getting back to your balance. It's kind of like that. It's like if you can't get the support you need when you need it, it's going to be much harder. So this is another factor that definitely influences communication. There are a lot of changes that already occur in all of us, Parkinson's or not, that are related to our age and affect your vision and your hearing, and it's just a fact of life. With Parkinson's, however, there can be some increased influences, especially for vision. And people with Parkinson's often have changes in their ability to recover from like a bright light. That's why people report having difficulties when they're driving and someone's got those annoying halogen lights on and it blinds them, and it takes a lot longer to recover from that. Contrast sensitivity, where you're able to see different shades of gray, make driving at night hard. And so these changes in vision and in hearing, plus what happens as we all get older, can influence because you're not taking the information in as well. Again, just like if you were leaning forward and not taking all the visual information, if you can't see well, if you had a cataract, for example, that's going to take the amount of information you're taking in down a bit, and that's going to influence your ability to be able to communicate better.
I often have people saying, let me put on my glasses so that I can hear you better.
Yeah.
So you can see. Also, we also had a lot of this experience in COVID, right? When we had people with masks and then you're trying to understand them. It's not only the limitation of the mask itself, is you're not getting the information from the mouth, right? Very
much so. You know, I again, if you doubt it, when you're communicating with someone, just have them put their hand in front of their mouth a little bit and it's not the audio. I mean, the audio is important. You're blocking it. But you'll be amazed at how much visual information that you're taking in. And some of it has to do with that nonverbal stuff we're talking about before, and some of it's just shape of the sound.
I was thinking, John, that could be actually a good exercise for people to do at home. Cover your mouth and then try to say the same thing. And then say, it can be a good cue for you to train, reinforcing, saying the same thing in with the different perspective, right?
Yeah, and how much effort it takes. There used to be a little a screening protocol we do when we go into in grad school, and it's called the Ling 6. And you'd say certain sounds that were similar, and you put your mouth in front of them and see if they could hear it, because certain like high frequency stuff. So yeah, it's a great idea. Mm-hmm. We'll play with it.
It sounds like an exercise. Somebody actually a game for Christmas Eve or something like that.
Yeah, I always thought you were going to do it in a class sometime, but yeah. Okay, well, yeah. So vision and hearing, highly correctable. We'll get into that in a minute here, but it's very much something that is going to influence communication, and we don't think about it.
and which is easy to get some help right on it. So it's reversible issues that are challenging.
Well, not just reversible, like light switch reversible, you know.
Yeah.
So now
we wouldn't say it's not. So these are also reversible, so treatable. Let's call it treatable. So anything that affects your mood, depression, anxiety, apathy in particular. Who wants to talk if you are completely indifferent of what's happening around you? Communication becomes really challenging. So obviously, understanding why, if there is a cause, to justify the depression, the anxiety, and the apathy. So it's something that is worth discussing with your neurologist. And in the next consultation, I'm going through this, see how it's affecting you. We might not think so much as I'm just sad, but the sadness, in feeling that you don't have control, or in terms of anxiety, is definitely going to have an impact about your social communications that you're having. And the relevance of that is actually also linked to cognition. So the less social we are, the more cognitively isolated we are as well. So
absolutely. And if you're distracted by the anxiety because you're thinking of whatever is the thing that's making you anxious, it can really it can influence your ability to attend. And we're talking about with communication, with language. You're being in the moment and having a conversation. It can influence that.
And I was actually thinking anxiety sometimes can lead to the opposite, which is talking too much. So talking too fast and excessive talking as well, because of you're so anxious to get something out. So
yeah. Okay, so those are definite influences on there. Definitely something to talk about with the doctor, because there are some ways that they can address that, especially the depression and the anxiety in particular. And again, it's just one component, but if you can keep chipping away, working with your SLP, you can certainly improve the mechanics of it. But if you can take away some of these commingling factors, it'll have a real influence on your ability to communicate better. Fatigue.
And here comes a very strong one, right? Who wants to talk if you're tired?
Yeah.
If you are in an environment that makes you even tired, you won't be engaging for sure. So I think fatigue is a complex symptom of Parkinson. It can have lots of factors that may influence it. And just for the simplicity of our talk today, it's worth mentioning to the medical specialist that's following you that this fatigue is having such an impact on my life that I am not communicating as much. I'm not talking. I'm not going out with friends. So they usually will address that in terms of asking you how it impacts your daily activities. But in case they don't, you should mention it, because it's the impact that makes the doctor act more on the problem, right? Because he wants to give you quality of life. That's why they're trying to help you to improve that.
Yeah. And there might be something that they can actually address, whether it might be related to a medication, might be related to some changes in your sleep function that they can actually address with it pretty effectively. Just idiopathic or of unknown cause fatigue is fairly common in Parkinson's. So again, it's a nice conversation to have with the doctor to see what you can do to address it.
Yeah. If we just say I'm tired versus, I'm tired and it's really making me not feel like doing exercise or going out or talking with anyone. You can see that these two sentences are very different when we are in a consultation and reporting symptoms.
Yeah. I mean, she's hitting on something really important, which is the impact on your quality of life, the impact on your socialization. And I think those both go really hand in hand. We're finding so much more about the social prescription for quality of life. Now, related to Parkinson's, there are some pretty specific cognitive challenges that occur, and they will definitely have their influence on communication. And probably the most common one is the word finding, or the retrieval of words. And again, this is coming directly from the survey, and I could probably put some more, but people talking about can't remember the word I wanted to use, can't find the necessary words, difficulty in putting thoughts into words and searching for words. I always call this like a tip of the tongue, but it can be more complicated than that. And that issue in Parkinson's is pretty common. It's something that people will report a lot, and it's not a memory loss in a sense, like you can't remember what you were completely talking about. It's like it'll come back in a couple minutes. It'll show up over time. And that tells you that the memory was made. It's just accessing it. It's a retrieval failure. And it's something that can really it can be frustrating in conversation. And you should have some techniques for, like, hey, give me a minute and I'll come back to me. You have some ways to address it. But it is something that's pretty common. It definitely has an influence on communication.
I was going to say that I had this experience this week, and so I was assessing someone, and the woman kept having difficulties in finding the word, but she had a strategy, which was the sister came in as well. And so it's when she started having difficulties, the sister would complete the sentences, and then she would have difficulties, and the sister would complete and that seems to work with them, right? But like as a health professional, or if you are with someone where this is happening, what I usually do is like, would you like me to complete it or not, right? So it has to be something that the strategy that we're going to use to be able to deal with the problem has to be, I wouldn't say negotiate, I'm looking for the right word, planned with the people that you are with, so that you become more comfortable in that, that you are aware that this can happen. And so you have these strategies, oh, never mind, I'll tell you in a second. Or they actually help us. I mean, there was a moment when she actually asked, tell me the word. So this was actually the first time that someone was actually telling me, I want you to complete my sentences, which is something typically that we don't do because we wait for the person to get it.
You certainly don't assume, but negotiation is actually a great term for it. You can arrange this ahead of time. You can have a conversation with your significant other or whoever is in the communication with you. You could even have a cue for that. Sometimes it's just easy enough, like, it'll come back to me, or you'll describe around it and it'll be enough. You don't always have to be precisely articulate and right on top of the words, you know.
Yeah, my concern in this is, in this strategy particularly, is if you have someone that's always filling in the sentence, is that you get used to it. So that means you are going to make less of an effort in terms of cognitive. And I'm highlighting this example because when I was on the phone with the same woman, she asked me to complete her sentences. You see, so that dependency is built even with people that you might not know. So just worth thinking. It's just sometimes things happen and we look at it in different ways.
Yeah, absolutely. And we'll get a little bit into some ways you can address it and treat it as well. So for those of you who come to our classes, you know about the influence of dual tasking, trying to do two activities at the same time. A lot of times we like to use voice alongside something, and the first thing that happens is the voicing gets quieter. Then maybe it takes a little bit longer. There's a lag in response times, and maybe the word gets distorted a little bit. Either you change the lettering a little bit by accident, or maybe the way you make the speech sound is. And again, we're in a class and we're going through it real time. When things get real quiet, we know that the exercise has gotten a little too complicated. And it's that same thing in life. I mean,
and the opposite, when we hear too many voices, it's like, this is getting too easy, so It's time to make it more complex. Or I'm losing everyone's movements because I can hear them so well, right?
That's really what it is.
There is a compromise that we know will happen, and that's okay, because what we are aiming to train when we do this type of training is to capacitate you to have more, I would say, more ability to fight against that interference that usually happens. We know there's an interference and we need you to be stronger against it. And so, yes, your movements will become slower, your posture might change, and there is some sound that the voice can also change. And these two, when you're in those moments of exercise, that's okay. We know, we accept that, and we change it because of that, right? We shouldn't come to a point where your posture is so bad, but your voice is really good, or the opposite, right? I wanted to highlight here the dual task in terms of the balance. And obviously this is where we have more concern, because when we are walking or standing position, as I was mentioning before, it's supposed to be automatic. So keeping our posture upright, keeping our balance is supposed to be a function that is automatic. But unfortunately, because of Parkinson, it isn't. So that means when we add on something else, which we are talking, then we are doing two tasks. And the two tasks here is balance and posture. And then sometimes we don't think about that because we think doing two things is, I don't know, looking on my phone and walking at the same time, but not necessarily. So keep in mind that balance is compromised when we are talking with others. And so we should try to look for ways to reduce that, I would say, stress, either on if you want to favor the communication, just hold on to something. If you want to favor the balance, and then in that case, we talk less.
Yeah, you listen more at that time while you're trying to take that in. You don't practice texting and walking, not just because it's not that functional, but I think you're a bad human being if you're the person walking in front of me when I'm at the mall. I'm like, I can't believe I got to navigate around this person.
Unfortunately, like our lives is all based on our phones, right? So your granddaughter texts you and you want to see the message and you're walking. It's just, I think what we can do about that, because it's so integrated in our daily life, is to just make people aware that this is an issue and that this really places you at risk. So if you think about why no one falls on purpose, right? We fall because we're distracted with something else, or something happens, right? Most commonly in Parkinson. Yeah. But just being aware of this so that you can look at what happens during your daily life and how you can maybe use this knowledge to make it safer.
One other factor that can sometimes influence communication is DBS, or deep brain stimulation. And that's when the surgeon puts electrodes deep into the brain and then it uses a power source to provide regular stimulation. And DBS provides a lot of the same kind of benefits that you would get from a medication, from a dopamine replacing medication. And again, like medications, it can improve certain parts of your speech for sure. It can improve the speed and the articulation and maybe volume. But one thing that happens with DBS is where the electrodes go into the brain is very close, frequently close to areas that are going to control speech structures. And so sometimes you will have a voice issue that's related to the DBS. And often what you'll do for that is you go to the doctor and they program that until you get the best movement and the best performance physically with the least impact on the voice. And so it's something to be aware of. There are newer versions of deep brain stimulation electrodes that have current steering, and that's getting more sophisticated. And the doctors are also getting quite sophisticated with the programming and can even program remotely, program telemedicine. So it's something to be aware of. It's not something to make a decision like, I'm not going to do this because of this, but it's something to be aware of. And if you're dealing with it and you have DBS, you might need to get that addressed by a doctor. Okay, so we're getting into a little bit about how is it best managed. And I'm just going to check, make sure we're not missing anything in the chat.
Anyone wants to ask a question?
Yeah, we're going to get into treatment here now, but anyone have something that's come to mind before then?
No.
Okay.
Silence is bliss.
Yes. Or it's a really hard exercise, one of the two.
Yeah. Now we'll have time.
Okay, so again, looking into our surveys and asking people, have you received any advice or recommendations from a healthcare professional or a therapist? Probably a speech language pathologist, but it could be others. And 60-40 split-ish. So 40% have gone to probably a speech language pathologist to work on communication, and the others have not yet. You can, and this is the results of that. These are the recommendations that they got directly from their SLP. So taking a deep breath before you speak, again, that speaks to breath support. Diaphragmatic breathing exercises, again, breath support, making sure you have a proper flow of air. Enunciation, being careful so that you're not rushing through things, as she mentioned, sometimes that happens with anxiety. Giving the context so that the communication is focused, and that's a really good selection, because when you have that situation, it can be very helpful to understand what you're trying to talk about, and that breaks it down much easier. And if you have a communication breakdown, that's probably the first thing I do is like, what are you talking about? You're talking about the what we're having for dinner. You're talking about what's on TV, and that makes it a lot easier. Over here on the far side here are a lot of treatment programs. Branded approaches, as we call them. So there's the LOUD program, which is also LSVT. Now it's LSVT LOUD. Speak Out is another version of those, and people who are doing those treatments, and that's usually with a speech language pathologist, almost always with a speech language pathologist. Another thing that's important is to address reversible factors. So again, if you have a hearing loss, consider getting a hearing test and getting hearing aids. And this used to be a heavier lift, But recently, the FDA has approved over-the-counter hearing aids for a lot of mild hearing loss. And so there are a lot more options out there and a lot more affordable options. And often these integrate into your phone. And so there's a lot of value from that, because if you hear better, you'll be able to hear the conversation more readily. It won't take as much energy. And that's the thing I'm mentioning. Obviously, if you hear the words, you're going to be able to talk better. But more, it's about the amount of energy. If you can't hear very well, if it's difficult to hear somebody, you're going to spend a lot of energy struggling, and that's going to take attention away from you trying to be part of the conversation. And similarly, vision, again, you should be addressing that with the doctor, because all the options we have now, you almost have no excuse. And anybody dealing with any cataracts, I've heard that surgery is life-changing. It's like, oh my gosh, all these things that I wasn't seeing before, coming back with vibrant colors and coming back very quickly. It's just a surgery.
And the others is obviously what we talked about in terms of other symptoms in Parkinson that are treatable, like the anxiety, the depression, the fatigue, and that might be influencing your communication, and maybe you haven't thought about that impact.
Yeah, we often and we've gotten a lot better, especially as there's so many new options of medications on the market now. But in the past, it was very focused on what's the movement related stuff, what can we address with it. But now the doctors have a much wider palette, and the doctors that work with a lot of patients really understand how to work that palette in a way that can be very beneficial. So don't be shy about asking about that before your doctor. Just to highlight the two big branded approaches that people were talking about, LSVT, or LSVT Loud, as it's really called anymore these days. It started off as Lee Silverman voice therapy, and Lee Silverman was the first person that they used it with many, many years ago, back in the 80s. And it consists of a lot of training to focus on using loud voicing at all times. You start with just working the voice and exercising the voice, and then you use it in context with short words, phrases, sentences, paragraphs. You work this hierarchy. And what's interesting about this is it has a lot of research support. It has some what we call level 1 evidence, meaning a double-blinded, randomized, controlled study. And double-blinded studies are very hard in our profession, because you got to find people that you'd have to find a clinician that doesn't know what the state of the art is, and then train them in a fake protocol. It's a lot of work. So they've done really a lot of heavy lifting to get their evidence out there. That having been said, I modify it quite frequently, so I wouldn't call a lot of what I do LSVT, just because they're so careful with their brand. They don't let it be done in a way that's not their protocol. So here's a modification. When instead of a loud ah, I'm using movements with that, and I'll just even play it here. So we'll do that. So we're using a dual task. We're doing the speech sounds, but we're using that high intensity, and the intensity is what matters. It's a calibration.
Serves as a cue, right?
Yep.
It's using your open up more.
And now I think we're spelling the words with letters. Yep. So again, the concepts. There it is. Oops.
That was just a cue for you to correct your posture, see if everyone's okay.
Yeah, it was loud now. The idea is again making the volume louder, because we know that people with Parkinson's perceive their voice louder than it really is. It's the misconception, and that connection is very valuable. And then how we apply that is different.
And I must say the combination is interesting, because sometimes people don't feel so comfortable, at least in my culture, people don't feel so comfortable in opening up the mouth and saying ah and stuff like that. So once you put movements to it, it's almost like you in a choir or something. So it just makes it more engaging as well. Right?
Yep. And it's a very cultural thing. I couldn't say think loud over here. That would be not right. It's mais alto, more power, right?
Yeah.
Yeah. So it just different people, different populations.
Culture plays an important role. It's important. Sometimes it's very neglected in studies.
Yes.
And so it's like if you have a population that doesn't open up so much the vowels, then it's normal that they'll have more difficulties in communication. And then telling that person now you have to speak really loud is a contradiction of what the person knows. as part of their culture, right? So it's therapists have to keep this in mind.
Absolutely. And if you're not using as much opening, as much vowel space, then yeah, it doesn't take much for it to disappear to really become much less intelligible. I wanted to be sure that I talked about LSVT Loud, which came first and became the gold standard, and we used it a lot, but they have a competitor called the Parkinson's Voice Project, and they do something called Speak Out. And it's another very good program that has a lot of practitioners, and they actually have standardized their materials in a very nice way to make it very easy to replicate. And they use some of that cognitive load that we were talking about before. So it's kind of nice. So it's another one, and they have something called the Loud Crowd, right? And they have other carryover programs. So it's a nice program. I like them a lot. You can use technology now to actually improve your volume. And this is an interesting thing that's been around a long time, but they finally have got it refined. And more importantly, they have Medicare reimbursement. So it fits in your ear, almost like a Bluetooth device. And when it senses that you're talking, it pushes loud, basically multi-speaker babble, as it's called, but basically people talking in your ear. And because they're talking in your ear, there's a reflex called the lumbar effect. And because it's a reflex, you don't have to train to it. It just happens. You get loud noise in your ear, you automatically talk louder because you're trying to talk over that annoying noise. And it works very, very effectively. There's interesting research that they've done because over the years they figured out different ways to prompt people. But they actually published a study about a year ago now, where they were using this in conjunction with traditional therapy and found that it was better tolerated. So if you've tried loud, if you tried speak out, and you're having a hard time keeping that energy level, this might be something to incorporate into the mix. And again, Medicare now reimburses it. Although your speech therapist should work with your speech language pathologist. They actually have an app, and you can test it first, so you don't have to pick it up and buy one first and then decide whether it makes sense for your system.
I was thinking of some restaurants that do this automatically, right? Where people, as they drink more 1 cup or 2 cups of maybe beers, and then the sound is so loud that everyone is shouting at each other.
Yes.
Well, that's a natural environment where you can also train, I guess.
Yeah, I mean, I don't know how much beer you can do on a day-to-day to make it volume.
No, it's not the drinking. It's the
loud restaurants. Yeah, the loud restaurant. Well, that's exactly what it was. Actually, there's been a lot of studies over the years that tested using loud noises in the ear because it's a reflex. You can't resist it. It happens, and you all of a sudden it just turns on. But what they found that if you use noise like a white noise, like a static on a TV when it doesn't reception, you would tune it after a while. Your body gets, that's not an important noise. So the multi-speaker babble with this is what's interesting. It's like a restaurant noise. See, a lot of people, and for some reason, because we're human beings, we can't stop trying to listen. It's like, did they hear my name? Did someone say John there? And we can't get away from that. So it's kind of funny how they've managed to hack that system. But speaking from startup world, the fact that they've managed to get through this and get a Medicare reimbursement, that's the real big deal. That's a game changer. So I'll stop bloviating about it, but it's very interesting. I think that something that we've come a long ways with is using breath training, and it's something that I almost always recommend we incorporate in some of our classes. And by working on strengthening the breath structures, you get obviously better support. It becomes more naturally and easy, but you're actually working on some of the sphincters, and it has some other benefits for Parkinson's. And in some of the research initially especially for the EMST device on the left, actually showed benefits for swallowing before they had research that showed benefits for voice. Of the two, one is what's called a threshold trainer, which means that you have to get to a certain threshold of pressure and the valve opens up. And then the other one is a resistance trainer, which means that you put these little baffles in there and you click them into place, and it provides resistance against your breathing. And both of them are valid for different reasons. But the EMSTT has a lot more research specific to Parkinson's, most of it coming out of the University of Florida, which has a very long history. Their speech lab actually Michael Oken, the medical director for the Parkinson's Foundation, that's his clinic. So good legacy everywhere, but their speech department has published some really great research for like 30 years. So I'm not picking one. I have no affiliation. There's a reason why I would use a breather in some situations, but I almost always start with the EMST 150, which you can just buy on their website, and it has some value for sure. Now, another thing that's interesting, I think, is just finding ways to increase your opportunities to talk. And sometimes you can just practice reading out loud. You can read something that you're reading in the paper. You can practice something that you might read some junk mail or something like that, just to give your voice some workout. I like to use speech recognition on my phone whenever possible. I use Siri whenever on my phone. We have Google Homes, just to find ways to interact. And what I like about that is if you're performing it properly, then you'll get good results. Google will play the song you asked for, your text will come out properly. And so it's a nice bit of biofeedback. And then I like a lot of volunteer and community opportunities, including choirs. And we'll get into choirs here in a hot second. Before.
No, today I had an aha moment where I thought, you know how we tell people that they should do 10,000 steps? I wonder if anyone has thought about telling people how many words they should do per day. So I actually was looking into this, and sure enough, this is not a secure source of information. It is Wikipedia. So, but they've actually tried to have different approach. I think there were different studies, and something showing like between 6,000 to 16,000 words per day seemed to be the average.
That's like Portuguese to American.
This was American data, so it was from. So obviously this is not secure. It's just for us to make this an analogy that we usually in the physiotherapy saying 10,000 steps. So be aware that eventually someone's going to tell you need 16,000 words, and we'll need something to register that, right? So our Fitbit will soon be counting our words as well.
Well, and actually there's a body of research from Karolinska in Sweden where they were using something called the vocal log to do something like this, not just intensity, but frequency and amount. But I don't know if they quite got into every word, but you can count syllables. So I like the idea, a Fitbit for your voice or for your speech. We'll get there. Or that sounds very Orwellian. Maybe it's terrible. Yeah. So when you're addressing word finding, the issues that we were talking about before, that tip of the tongue, the things that you think may be really beneficial, like crossword puzzles and stuff like that, actually don't seem to have that much benefit when you look at the research, and that's just a matter of naming on demand is not something that we do that frequently. You're not at work, like, ding, give me 15 words to begin with the letter L or you're fired. It's not going to happen that way. So sometimes that training might not be as efficacious. What we find is if you're going to do something like that, add it in with some other exercises, some dual task exercises and things that are cardio, because that helps with consolidation. And by making it dual task, that's more likely the way you're going to be calling upon those faculties. And that's why it's a nice way to do it. That's a very big part of why we do our exercise the way we do.
And it can be simple things like just standing position or sitting and standing, which is a simple activity. Because we might be sitting and we're reading something, and then somebody calls us and they start asking stuff, and you're getting up from the couch and you're talking at the same time, and then suddenly you fall back because there is an interference when we're doing two things at the same time. So if we can train those activities with things that are meaningful in daily life, it will have better results. It will mimic those activities, and it will give you more capacity to deal with them.
I wanted to put something here because it's something that came into the survey a little bit, but choirs, singing, is this a good way to exercise your voice? And for sure, it is great socialization, and we think that the kind of interaction is valuable. Remembering the words and making sure you have the phrasing, and if you're reading music, if you're in that kind of choir, really great functional cognitive work for sure. That's excellent. And obviously you're working your voice and your breath. And I think there used to be some vibe in the days like, well, you don't sing, you talk. And it's like, yeah, but a lot of those muscles are similar. One thing I'll say is it's not a replacement for working with an SLP. It's a great add-on and it has a lot of value and it's fun, and you should consider doing it, but I'm not saying that. But one thing when you look at the body of research is that when you see a choir for Parkinson's, the results are usually not great until they bring in an SLP to do even just a session in a week. So it seems like the combination really seems to help. So you can hack that for your own purposes. Do the choir, but don't skip the SLP, the speech language pathologist. So I think I'm going to stop here and maybe take some questions. And if we don't, I can always get into a couple other things. But I just want to make sure. Does anyone have anything that they wanted to ask? I'm waiting for someone to pull up there. I have a couple of things that came here. Someone trying to come in. I'm going to look over there. I have a couple questions that I can pull from our surveys. Okay, jump in if you need to. When you talk about a gradual onset of speech problems, what does that look like? In some ways, speech changes have probably occurred before your formal diagnosis. Like loss of sense of smell is what we call a prodromal, or before the formal diagnosis. Often it happens slowly. It happens a little bit at a time, and if it happens far enough back in your lifetime before your actual diagnosis, it might even become a little bit of your personality, and it might reinforce itself. I remember a couple times working with someone where they're like, "Hey, I'm very serious. This is the way I talk. This is the way I'm not a showy person." And obviously over here in Portugal, again, if I hear someone, we were at a coffee shop over the weekend. If you hear someone being loud, you're like, "Oh, there's another American." Oh, and then sure enough, there's a guy from Michigan. It's like you can hear us coming. You won't hear that in Portugal. So that's what I would say. It's going to start by being quieter and maybe taking more energy. You can have other manifestations. You can have issues with stuttering or fluency or something like that. But again, the word I like to use is insidious, because insidious means that it's happening slowly and in the background with negative effects. So it's happening slowly, chipping away at your abilities. And luckily, using LSVT loud, using Speak Out, working with a speech language pathologist, you can definitely change that. You can definitely influence the real hallmark quiet speech of Parkinson's. Tips to speak louder. Oh, someone's got it. Which medication specifically is helpful for speech? And again, the issue is that anything that's going to improve your ability to move, your ability to have faster movement, have larger movement, is going to have an influence on your ability to speak, at least for the parts related to movement. So the articulation and the speed. It would be the same if you were dealing with swallowing. Oh, those components are going to definitely improve. But what I will say is that it doesn't generally turn into better intelligibility. I think you want to be able to address your communication ability, and the medications are there to give you the best motor support, movement related support, but you're still going to probably need to work a little bit with an SLP. Someone put something in about phlegm, and I have one right here. How can one clear the throat when it seems to have phlegm in it? And the first thing I'm going to say is that sometimes people deal with a lot of postnasal drip. If it's happening at a mealtime, I'm starting to wonder whether that might be an indication of a swallowing problem. So that's one reason to get a referral to a speech language pathologist. If it's something that's allergy related, that'd be a reason to talk to a doctor, because there might be a medication you can take that can improve that and not make it so prominent in causing that problem over and over again. And reflex could also be part of this issue, and another reason to talk with a doctor. But I think when you have phlegm and you're trying to clear your throat, if you do that kind of what we all do, that's actually fairly abusive to your vocal folds. You're bringing your vocal folds together, and they're very soft little tissue. It's like the inside of your cheek. So what I tell people to do is kind of what's called a glottal coo, where you kind of make an H sound. You try to ha, ha, ha. So your vocal folds don't actually come together, and it's less abusive. It's more work. So again, while you're getting to the root cause of the phlegm, you can use that, but I would be trying to see, do I have gastroesophageal reflux disorder? Is there something I can be doing with my diet and my doctor to improve that? Do I have an allergy? Can I be addressing that? Is this happening when I'm eating? Is there possibly a swallowing problem, and my body's natural defenses are turning on to give me that problem? So those are the things that you should be doing to address. And one, you have to clear your throat. think about doing like a really, really strong H sound. Ha, ha, ha. It's almost like you're trying to make the back of your throat vibrate. And that way you're not bringing the vocal folds together. You're not abusing the vocal folds. And that can give you better results. So, someone about PD symptom there, and I'll make sure I'm missing it here.
No, everything's good.
Oh, yes.
Awesome.
Good. Yes.
Awesome.
Yeah, that was the one about phlegm. Very good. Okay.
So these questions that we are approaching now were questions that were placed in our questionnaire. Yeah. So it's we have your voices here the same. I think so. The last one was what? What are some tips for speaking louder?
Oh, yes. Okay. Well, speaking louder again, well, I think we've gotten into some of this when we start talking about posture and breath support. But again, if you're dealing with a situation where you've done that, you're making yourself take a nice big breath before you start and it's still too quiet, that probably tells me that the vocal folds are weak and you're getting a little bit of atrophy and maybe you're not getting as much sound. That's probably why you want to see a speech therapist. If you want to test that theory, you can pretend like you're pushing yourself out of your chair. You can get a little bit of effort, or you can push your hands really close together, and all of a sudden, if you can be a lot louder, if you push up like that, well, that just tells me your vocal folds are definitely not there. You would see an ear, nose, and throat doctor before you begin speech therapy. It's common practice, and they would be able to see that with the scope, with their lens. But again, I have tricks where I can hear it. So you can be. Oh yeah, here we go. So I can be. If you've done the things to address the basic components, and you're still too quiet, get thee to a speech therapist. Work with a speech language pathologist. Optimally, one that is associated with a movement disorders clinic or a neurology clinic so that they have a lot of experience. And at a bare minimum, one that has undergone either LSVT or speak out training, or both would be better, because that means that you got another nerd, and we like nerds. Nerds are good when you're getting treatment.
What I hear often people saying that the neurologists, when they do talk about it, it's most often the Lee-Silman Loud program. So and this is just because it's part of their guidelines as well in terms of recommendations and referrals. So it might be what they know most, but that doesn't mean that you can't share that these other options exist as well.
I Speak Out has done a very good job of building a network, and a lot of them are at universities, and so they got the next generation of therapists. So if you went to someone who was only trained in Speak Out and not LSVT, totally fine. They're very good. They'll be great. But one or the other, it's kind of a bare minimum. I have both, and I have some other certifications because I try to keep up on stuff. But one of them, just to have a core knowledge of what it takes to really get someone with Parkinson's to communicate better.
How often do you think people should do it? Because it's 4 weeks.
Yeah.
What would be the frequency of?
Well, I mean, I think you would try to do the course initially the way they design. This is another issue with the LSVT, is that they want you to do it 4 times a week for a month to get the right intensity. And they're not wrong about that. And they've done their research. But that can be onerous, and that can be a little bit hard on a Medicare system, especially if you're working with a physical therapist at the same time. So you might have to make some changes. I don't think that the LSVT people would be interested in hearing me say that, but that's just the reality we live in. After you do that course and you come out with a good outcome, your therapist has done the work, you've done your homework, you're going to pop in maybe every 6 months, and no less than every year, to get a checkup, make sure that everything's doing well. You might need to come in for a couple touch-up sessions. This is also why you should come to the online classes that we do with the IPMDC, or the in-person ones that they also support, because you should be exercising your voice in between so that you can maintain those gains. So it's not all therapy. It can also be classes and fun. Is that fair?
Mm-hmm.
All right, folks, we're a little bit over, but I'm happy to answer any questions. Otherwise, we will have this video and the slides available on the ipmdc.org website. That's the Inova Parkinson's and Movement Disorders Center, our partners in these programs. And it doesn't take very long, maybe a couple of days. They'll be available right there, and you can watch anything that you missed. You can read through the slides and capture any information that you wanted to go over again. Okay?
Thank you all for coming in. I hope this was useful information, and it will be practical things that you can use in your daily life tomorrow.
Thank you.
Thank you very much.
Thank you. Thanks for coming in. Have a good night.
You too.
See you next week.
All right, folks, take care.